Good morning, everyone. My name is Darlene Rose, and I'm here to welcome you today to our webinar. I'm Regional Director of the Champlain Maternal Newborn Regional Program. The title of our webinar today is Understanding the Factors Shaping Pregnant People's Experiences, Choosing and Accessing a Maternity Care Provider in the Champlain region. I'd like to start with a land acknowledgement. I'd like to begin by acknowledging the land on which CMNRP operates. We recognize that CMNRP's members and stakeholders are located on traditional Indigenous territories across Ontario. The CMNRP office is located in Ottawa, which is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. I encourage you to reflect on the land you are on, who the traditional keepers of the land are, and what the treaty relationship is, or if it is unceded territory. Recognize that Indigenous practice of health and well-being have been in place in this territory since time began, are maintained to this day. Welcome, good morning, bienvenue. I'd like to introduce our speaker for today. Carolyn Chamberlain-Rowe is a doctoral candidate in health systems management at the University of Ottawa's Telfer School of Management, where her program of research has focused on health workforce policy, planning and management with specific applications in maternity care, primary care, and mental health care sectors. Through her work in this area, she's been invited to serve as the maternity care thematic lead for the Canadian Health Workforce Network. Carolyn completed a CIHR-funded Health System Impact Fellowship with CMNRP and has recently transitioned into her new role as a health outcome scientist at the Nova Scotia Health Authority. Welcome, Carolyn.
Thank you, Darlene, and thank you so much for that introduction. I'm really looking forward to speaking with everybody today. I'd like to begin with a few acknowledgements. So this project was funded through a Women's Exchange 15 Key Challenge Grant and CIHR's Health System Impact Fellowship Program. This project, which constitutes my doctoral dissertation, is being conducted under the supervision of a thesis advisory committee led by Dr. Ivy Bourgeau, in consultation with an advisory committee of community collaborators, and in partnership with the Champlain Maternal Newborn Regional Program. So I'll pass it over to Darlene to provide some context that shaped this work.
A little bit of background and some of the factors that led to this work. Seems like so many years ago now, and certainly at my onset here as regional director of the program. In 2017, PCMCH, the Provincial Council for Maternal and Child Health, released its low-risk maternal newborn strategy, of which the central objective was supporting a system of care that provides women and their families with equitable choice in birth environment and provider. In theory, pregnant people in Ontario can seek maternity care from a midwife, a family physician, or an obstetrician, but the practice still remains constrained. In phase one of our regional capacity planning in 2017, there was large consultation with families, healthcare providers, and community organizations. CMNRP identified at that time variability in the availability of different healthcare providers as a barrier to optimal access to perinatal healthcare. Finding three in physician capacity was an important consideration in planning future maternal newborn services, particularly in the lower volume hospitals in rural areas. In the fourth finding, a demand for midwifery services is increasing and appears to exceed existing capacity in certain areas within the LHIN. And finding number 7 was that meeting the needs of the LHIN's rural populations likely required maintaining all existing obstetric programs. However, low expected growth implied a need to explore changes in the mix of provider types over time. And then in April of 2019, our KPMG Regional Maternal Newborn Capacity Report was released with the following recommendations. Recognizing that obstetricians, family physicians, and midwives play a critical role in providing low-risk maternal newborn care, their respective roles should be considered in the context of each other's to promote appropriate access and care. This should be done by bringing stakeholders together to establish the appropriate provider mix for each community now and in the future, while exploring innovative integrated models of care. And in addition, given women in the region requested increased access to midwifery services, midwifery privileging processes at each hospital were to be reviewed, and opportunities to increase the number of midwifery supported births at the Ottawa Birth and Wellness Centre were to be explored. These findings and recommendations definitely indicated a need for more in-depth assessment, and I'm so pleased to turn the presentation over to Carolyn Chamberlain-Rose so that she can further explore her findings with you.
Perfect. So As a means of advancing our regional capacity planning, this project first set out to understand how access to the full range of maternity care providers was distributed across the Champlain region. Once we had described the distribution of access across the region, we sought to explore the individual, organizational, and system-level factors that are shaping access to the full range of maternity care providers and pregnant people's autonomy in choosing a maternity care provider across the region. Finally, we sought to identify locally relevant solutions that could be effective in alleviating gaps in access and autonomy. In order to achieve this objective, this project adopted a community-based participatory research approach using a mixed methods design that encompassed 2 complementary stages. In stage 1, we conducted a quantitative geospatial mapping exercise to assess pregnant people's access to the full range of maternity care providers across the Champlain region. In stage 2, we conducted qualitative participatory system dynamics modeling, employing focus groups and individual interviews to explore the factors that are enabling or restricting access and autonomy within the local maternity care system. Moving on and presenting a little bit more about stage 1. We drew on a survey of midwifery practice groups, as well as the CIHI National Physician Database in stage 1 of the study, and used ArcGIS software to map the service capacity generated by obstetricians, family physicians, and midwives providing intrapartum care across the Champlain region. Drawing on data requested from Born Ontario, the distribution of maternity care service requirements was then added as an additional layer of mapping. Using a variation of the enhanced 2-step floating catchment area method, a provider-specific accessibility index score was then calculated for each census aggregate dissemination area within the Champlain region. We then produced choropleth maps, which visually represent the provider-specific accessibility index score and allows us to compare relative accessibility within the region and across provider groups. An accessibility index score of 0, which is represented in white on these maps, indicates that the population in this aggregate dissemination area has no access to the provider group in question within the established drive time threshold, in this case 30 minutes. As scores increase and the shades of purple become darker, relative access to that provider group increases. It should be noted that these scores are relative measures that allow us to compare levels of access, but no particular score is a normative threshold for adequate access to care. Luo and Key propose a 2-step process to measure geographic accessibility of care and to identify areas of workforce shortage. The fundamental measure upon which the original methodology is built is a provider to population ratio. In order to build on Luo and Key's approach and account for a more nuanced representation of the match between service requirements generated by population health needs and the service capacity generated by provider practice patterns, our adapted methodology replaces provider to population ratios with service capacity to service requirement ratios. In this exercise, each provider's service capacity was estimated using an average yearly number of births attended as the principal care provider. Service requirements were estimated using the average yearly volume of births generated by residents, whereas service requirements for obstetricians included all births generated by residents. In the case of midwives and family physicians, service requirements were limited to births classified as low risk. All data input into this mapping exercise represented 3-year averages covering the period between fiscal year 2015-16 and fiscal year 17-18. This adaptive methodology allowed us to account for the individual provider's practice patterns when measuring the service capacity they offer within the local maternity care system. This adaptive methodology also allowed us to account for the unique demographic and risk profiles of local populations when measuring the maternity care needs they generate. Trying to click through here. In the first step of this adapted methodology, once representative points for providers and populations had been geolocated, all provider locations that fall within a weighted drive time threshold from each practice location are identified, and a service capacity to requirement ratio is computed for the defined catchment area. In the second step of this adapted methodology, a provider-specific accessibility index score is produced for each population located by location, calculating the weighted sum of service capacity to requirement ratios of all provider locations. Accessibility indices were produced for both 30-minute and 45-minute drive time thresholds. For some population locations, accessibility index scores will reflect their combined access to multiple providers' capacity. For example, if you live in central Ottawa, you will likely be able to reach multiple providers within a 30-minute drive time. For others, such as some suburban populations, accessibility scores only reflect access to the service capacity generated by a single provider. And finally, some rural population locations will have absolutely no access to any provider group within the established 30-minute drive time, resulting in an accessibility index score of 0. The weighted rings used in this methodology also allow us to account for the distance between patients and providers in our measurement of access. This acknowledges that providers whose practice locations is within 5 minutes of your home will provide more access to you than a provider who practices 25 minutes away from your home. So looking at the stage 1 findings, the residents of the Champlain region generated an average of approximately 13,000 births per year as a service requirement, of which an average of 55% were classified as low risk as per the PCMCH definition used by Born Ontario. As is depicted in these figures, maternity care service requirements for all levels of risk were unevenly distributed across the Champlain region, with some aggregate dissemination areas displaying a higher volume of demand for services than others. For example, Barrhaven and Orleans, 2 of Ottawa's major suburbs, appeared to generate a high volume of demand for maternity care. One ADA in the eastern Champlain region, which encompasses the growing rural communities that line the 417, including Limoges, Castleman, Benaston, and Saint-Isidore, also appeared to be generating a significant volume of demand for services. These figures also demonstrated that not all populations across the Champlain region share the same risk profile, with some aggregate dissemination areas displaying a greater proportion of births categorized as low risk than others. The cohort of physicians with postal codes of practice within the Champlain region who attended at least one delivery between 2015-16 and 17-18 included 104 obstetricians and 130 family physicians. At the time of data collection, midwifery practice groups included in this study encompassed a total of 91 midwives, of which 65 were permanent employees practicing full-time, 6 were permanent employees practicing part-time, 5 were locums, 5 were students, and 10 were on leave. While there were more family physicians than obstetricians in this cohort, the obstetricians' level of participation in the maternity care sector and the volume of deliveries they attended on a yearly basis far exceeded that of family physicians. In other words, this cohort encompassed a high number of family physicians providing relatively low volumes of intrapartum care. For instance, on average, obstetricians in our cohort attended approximately 105 deliveries per year, whereas family physicians attended an average of 12 deliveries per year. Furthermore, our cohort demonstrated that not all obstetricians practice in the same way, with obstetricians engaging in variable levels of activity and participation in intrapartum care. As such, our adapted methodology's ability to account for individual providers' practice patterns when measuring service capacity they offer within the local maternity care system proved to be essential to the validity of our measures of access. Using a simple headcount-based provider to population ratio would have led us to considerably overestimate access to maternity care provided by family physicians. Measuring the interaction between the service requirement and service capacity trends using the adapted enhanced two-step floating catchment area methodology, we produced the following maps of access to obstetricians, family physicians, and midwives who provided intrapartum care respectively. As is illustrated by the accessibility index scores displayed in all 3 of these maps, our first overarching finding was that access to all 3 maternity care provider groups was inequitably distributed across the Champlain region. When comparing relative accessibility across provider groups, the darker shades displayed in the map representing access to obstetricians translated into average accessibility index scores that were significantly higher than the average accessibility index scores for care provided by family physicians or midwives. Focus group participants in stage 2 generally regarded access to midwives and family physicians to be both inadequate and inequitably distributed across the Champlain region. While participants agreed that access to obstetricians was also inequitably distributed across the region, they deemed it to be generally adequate in urban centers, with some issues surrounding timely access to referrals and heavy workloads adopted by obstetricians in order to maintain this level of access. In some areas, access to one provider group was compensating for lack of access to others. This allowed for access to care without necessarily affording pregnant people the opportunity to exercise choice of provider. For example, the area surrounding Hawkesbury exhibited higher levels of access to family physicians, with minimal access to obstetricians and no access to midwifery care. Similarly, in the Barry's Bay and Killaloe area, pregnant people had relatively high access to midwifery care because of a satellite practice that had been established by one of the midwifery practice groups, but no access to any other provider group. Finally, with access concentrated in population centers like Ottawa and to a lesser degree Cornwall, Hawkesbury, and Pembroke, a number of smaller rural communities were left with little to no access to any provider group and forced to drive long distances and leave their communities to access maternity care. For instance, the Ottawa Valley region appeared to be significantly underserviced for maternity care, consistently displaying low levels of accessibility across provider groups. Participants in subsequent qualitative consultations partially attributed this trend to the closure of the obstetrical program at Renfrew Victoria Hospital in June of 2014. This provided a clear example of the critical importance of rural obstetrical programs and satellite practices to upholding care closer to home and of the effects that program closures can have on access to care. I'm trying to skip through. There we go. The ADA in the Eastern Champlain region, which I highlighted as a source of concentrated demand for maternity care earlier in the presentation, also appeared to be significantly underserviced, with low levels of access to family physicians and midwives and no access to obstetricians. This area also appears to be stuck in the middle, forced to drive long distances in all directions to access facilities and providers. I would now like to acknowledge some of the limitations of stage 1. First, the study employs average yearly number of deliveries attended as the principal care provider to measures of a service capacity. This is the most feasible proxy for a course of care available within our current data infrastructure, but does not necessarily capture transfers of care at any stage during the prenatal or postpartum or intrapartum period. Second, this study attributed providers' service capacity to an aggregate dissemination area based on their postal code of practice. As a result, this study does not reflect the full breadth of geographic coverage that midwives provide through home care and may misallocate the service capacity of physicians in the event that the postal code of practice available in administrative databases is inaccurate. Third, the most recent year of administrative data available was for fiscal year 2017-18. As a result, any trends that have emerged since April of 2018 are not reflected in these maps. Overall, participants in stage 2 have validated the accessibility maps produced in stage 1, confirming that they reflect their experiences within the system. These consultations with local patients, providers, and policymakers also mitigated limitations associated with the timeliness of administrative data by creating opportunities to confirm where trends that are reflected in these maps remain relevant and highlight any areas where change may have occurred. For instance, participants have identified select communities where trends may have shifted due to recent workforce recruitment or attrition. Finally, edge effects are a common limitation of geospatial analysis of defined regions that represent artificial rather than absolute boundaries. While data are limited to patients and providers that reside or practice within the region's boundaries, both residents and providers in and around the Champlain region are free to access and provide maternity care services within and beyond these boundaries. Now moving on to stage 2. We conducted a series of semi-structured individual and focus group interviews with patients, providers, and policymakers across the Champlain region. Participants engaged in the interpretation of quantitative results generated in stage 1, the exploration of individual, organizational, and system level factors that are enabling or restricting access and autonomy within the local maternity care system, and the identification of locally relevant policy recommendations. All individual and focus group interviews were audio recorded, transcribed, and thematically analyzed using NVivo 12 Pro. Between February 2020 and August 2021, we completed 20 data collection activities with 69 participants, including 20 patients, 28 providers, and 21 policymakers. Using targeted recruitment efforts and stratified purposive sampling, we endeavored to promote equitable representation across subregions, hospitals, stakeholder groups, provider groups, and patient groups. For instance, once we had completed our provider and policymaker focus groups, we completed a series of targeted individual interviews with representatives of hospital sites that had not been represented in our original focus groups to ensure that all sites had the opportunities for their perspective and experiences to be captured in our findings. Using these qualitative data, we were able to deepen our understanding of the geographic determinants of access that are reflected in the maps. Providers were concentrated in population centers that offered high density of demand and proximity to hospitals with obstetrical programs. This resulted in an inequitable distribution of access to the full range of maternity care providers and choice of birth setting across the region, requiring rural populations to drive long distance to access care, which in turn influenced the care options that were made available to them. These trends were attenuated by the presence of rural obstetrical programs and satellite sites, which were critical to the bringing care closer to home for these populations. They were also attenuated by midwives' ability to uncouple access to care from the distribution of facilities and cover large geographic areas through their provision of home care. Also, since the advent of COVID, the use of virtual care for a subset of prenatal appointments had attenuated some of these barriers. On the other hand, these barriers were compounded for parents who had risk profiles requiring frequent visits to tertiary care centers, lacked access to transportation, had inflexible employment models that forced them to sacrifice income in order to attend appointments, or faced inclement weather. One of the key drivers of the inequitable distribution of providers that was shaping these geographic barriers of access was persistent challenges with recruitment and retention of providers in rural settings. Participants explained that these challenges stemmed from a lack of exposure to, training for, and comfort in rural practice among graduating students. New graduates hesitating to take on amplified challenges associated with building a new practice in a rural setting, large catchment areas and small practice teams, resulting in demanding call schedules and compromised provider well-being, and rural facilities' difficulties generating sufficient volume to maintain the competence, ensure the financial viability, and justify the lifestyle of rural providers. Across both rural and urban settings, a vicious cycle of workforce trends appeared to be constraining potential access by limiting the service capacity generated by all three provider groups. First, limits on the number of students trained and barriers to the integration of available providers limited workforce supply within the region. This left passionate and dedicated providers adopting heavy workloads and demanding lifestyles to meet growing population needs within limited resources. These heavy workloads were unsustainable, leading to burnout, leaves of absence, and attrition. This was particularly true when providers were required to cover for various types of leaves of absence and to compensate for the lost capacity of providers transitioning into retirement without the introduction of new resources. This unsustainable level of activity was leading to decreased participation in intrapartum care. Fewer graduates were interested in adopting the lifestyle required to provide intrapartum care, and sub-providers who had the flexibility in their scope of practice to do so were either suspending or decreasing their intrapartum activities and on-call work. Participants noted that all of these trends point to the need for a sufficiently large workforce at the system level and a sufficiently large team at the organizational level to meet population needs while ensuring sustainable workloads and call schedules for providers. Participants also indicated that the current model of remuneration created competition for limited market share within the local maternity care workforce. This constrained choice by rendering it challenging for particularly rural programs to generate sufficient volume to maintain the financial viability of all three provider groups. It also impeded interprofessional collaboration by fostering tensions and disincentivizing interprofessional support. Finally, this competition led to suboptimal use and duplication of resources as a result of the absence of compensation mechanisms for integrated care. Participants explained that alternative remuneration and funding models could support pregnant people's access to the full range of maternity care providers by fostering innovative and person-centered models of collaboration that could provide appropriate levels of care at an appropriate cost to the system. The development of alternative remuneration and funding models was also seen as an opportunity to ensure the financial viability of establishing and maintaining practice, particularly in rural low-volume centers, and supporting flexible work arrangements and retention within the maternity care workforce. Under the current model of remuneration, hospitals appeared to be forced to differentially prioritize and support the integration of obstetricians, family physicians, and midwives into their obstetrical programs. First and foremost, hospitals were required to prioritize maintaining the financial viability and retention of obstetricians because of their reliance on obstetricians for gynecological care and surgical backup. In contrast, it appeared that within the current system, certain conditions needed to be met in order for hospitals to be enabled to support the integration of family physicians and midwives. Hospitals were enabled to support family physicians and midwives who provide interpartum care under three common conditions. Local obstetricians had established viable practices. The hospitals were seeking resource-effective program growth by bringing in new low-risk clients, and respectful and collaborative relationships had been established between the provider groups. Family physicians did appear to have an advantage over midwives in that many hospitals relied on their contributions to other sectors of care, including pediatrics, neonatal resuscitation, the emergency room, and primary care. This left midwives particularly susceptible to constraints on their privileging and birth volumes, which are used to maintain the practice viability of the other maternity care provider groups active within the hospital, upon which they so heavily rely. At the organizational level, facilities and policies and practices, including caps on birth volumes and privileging that results from these conditions, can pose barriers to the recruitment and optimal integration of providers into the local maternity care workforce. Participants indicated a need for more coordinated leadership at both the regional and provincial level, including the establishment of and implementation of a common vision and guidelines in order to foster an enabling environment for collaborative maternity care across facilities and provider groups. Turning to the patient and parent experience, participants highlighted the importance of primary care attachment as a gateway to access for information, referrals, prenatal care, postpartum care, and newborn care, and noted that for many pregnant people across the region, lack of attachment constituted a significant barrier to access and choice. Participants explained that this lack of attachment was caused by the broader shortage of family physicians, which was worsening due to inadequate replacement of retiring physicians and variable participation in interpartum care exhibited by the family physicians who are available within the current system. The consequences of lack of attachment included barriers of access to information and referrals and barriers of access to prenatal, postpartum, and newborn care. In order to fill these gaps in access, unattached individuals were forced to rely on walk-ins and emergency rooms. Furthermore, at times, lack of attachment resulted in suboptimal use of specialist care. At the individual level, in order to exercise autonomous choice, pregnant people must first be informed about the options that are available to them. However, participants expressed that there was a lack of awareness amongst both pregnant people and primary care providers in the region regarding the full range of maternity care provider options available and their relative scopes of practice and models of care. Obstetricians were the most commonly known provider, which meant that they were accepted as the default option by many. As for family physicians, participants described a general lack of awareness about this option unless an individual's primary care provider and or their team actually provided these services. Participants also communicated some lack of awareness about the characteristics of this provider option, including that they engaged in intrapartum care as well as prenatal care, and that they had received specialized training in maternity care. Finally, while participants acknowledged that awareness about and demand for midwifery care was growing through word of mouth, they explained that many people remained unaware about this option. This lack of awareness extended to the characteristics of this provider option, including their coverage under OHIP, their ability to practice in hospital, the pain relief options they could offer, and the breadth of their scope of practice and training. This lack of awareness was shaped by a number of factors that were constraining pregnant people's opportunity to exercise autonomous choice of provider. The local maternity care system was characterized by a lack of coordinated informational resources tailored to preconception and early pregnancy, variable support of informed choice by confirming providers, and variable access to information through personal networks. This placed the onus on pregnant people to seek out information, self-select into an appropriate provider group, and navigate access to their services. Under these conditions, two categories of individuals emerged. The informed self-advocate, whose knowledge of the process and options enables them to assertively navigate access to their provider of choice, and the constrained adherent, whose lack of awareness of the process, options, and characteristics prevents them from exercising choice on time to gain access to their preferred provider. In response to these informational gaps, participants highlighted the value of developing coordinated and tailored education and resources to facilitate informed choice of an appropriate provider by providing evidence-based information about provider options, the characteristics of these providers, their availability within an area, and the process to access their care. While numerous factors influencing choice emerged in our discussions, including risk profile, gender, language, culture, and preferred setting, as well as models of care, participants acknowledged that in the absence of coordinated informational resources to inform these decisions, the most significant factor shaping pregnant people's choice of provider was word of mouth and past experiences. Whether this information be transmitted through friends, family, or social media platforms, pregnant people who had become informed self-advocates had often first been made aware of these options through their informal social networks. Finally, through our engagement with local stakeholders, we were able to identify a number of social determinants of access and autonomy that widen the gaps I have just described. Young parents, parents whose first language is not English, people who have lower levels of education and literacy, people who have inflexible or insecure employment, people who have low income, people whose family responsibilities and characteristics tie them more closely to their homes, people of color, Indigenous peoples, people with disabilities, newcomers to Canada and the region, people who lack access to a vehicle or reliable transportation, the LGBTQ2+ community, and people who have mental health conditions or use substances, all faced amplified barriers of access and choice within our local maternity care system. I would now like to acknowledge some of the limitations of stage 2 before concluding with a framework describing the different factors shaping access and autonomy. So first, while we achieved a reasonably large sample size and endeavored to capture a variety of voices, we do not contend that participants in this study constitute a representative sample. These findings reflect the perspectives and experiences of our participants alone and may or may not reflect the perspectives of other patients, providers, and policymakers within our region. Second, data collection was interrupted in March 2020 due to the emergence of the COVID-19 pandemic and further delayed by my own maternity leave. As the focus of this study was not the impact of COVID-19 on access or choice, when data collection resumed in January of 2021, we adjusted our patient inclusion criteria to capture the experiences of pregnant people who had chosen and accessed their provider prior to the emergence of the pandemic. This adjusted our inclusion criteria and also resulted in an adjustment to our patient recruitment strategy. Unfortunately, despite our best efforts, patients who accessed intrapartum care provided by family physicians remain underrepresented in our resulting sample. Finally, we must also acknowledge that these findings do not reflect the perspectives of one hospital site within our region and underrepresented the perspectives of certain provider groups who chose not to participate in this study. So in terms of a discussion and a conclusion, building on existing literature, I have used these findings to develop a framework for the promotion of equitable access and autonomy in maternity care, which describes the structural conditions that would be necessary to equitably support pregnant people's opportunity, ability, and propensity to exercise choice of a maternity care provider. At the policy level, the framework posits that leadership, coordination, and integration across stakeholders, facilities, and provider groups is required to enable the development of a system of maternity care that equitably supports pregnant people's opportunity, ability, and propensity to exercise autonomous choice of provider. This system-level leadership, coordination, and integration is critical to enable the translation of maternal health policies that support access and choice in theory into structures and processes that fulfill these targeted outcomes in practice. The framework also divides the structures required to support pregnant people's opportunity, ability, and propensity to choose a provider into three key areas of intervention: the maternity care system, the birthing population, and the environment within which they interact. First, maternity care delivery systems that are equipped to support access and autonomy have a supply, distribution, and mix of maternity care providers that is aligned with population health needs, supportive of care close to home, and adequate to maintain sustainable workloads and call schedules. This requires particular attention paid to the sustainability of rural maternity care programs and to education, recruitment, and retention of rural maternity care providers. Furthermore, within such a system, educational, financial, organizational, physical, and technological structures should foster integration of and collaboration across all provider groups in person-centered models of care. Second, in order to avail themselves of the full breadth of resources available within this maternity care system, the birthing population requires direct access to information about provider options available and to the resources required to navigate access to their services. Ideally, access to information and maternity care providers is facilitated through attachment to a primary care provider who supports informed choice and serves as a gateway into the maternity care delivery system. System structures that promote access to information and resources limit the presence of constrained adherence within the birthing population, prevent the need for patients to serve as informed self-advocates, and level the playing field for the emergence of a birthing population that is equitably equipped, supported, and empowered to exercise informed choice. Third, through proactive strategies that offer equity-deserving populations with the resources to support their access and autonomy can mitigate the further entrenchment of inequities present within the physical, social, political, and economic environments. Cross-sectoral partnerships can supplement these efforts by enabling investment in upstream strategies to address the root causes of these inequities. These structures interact to shape the three prerequisites that enable pregnant people to actively engage in the process of choosing and accessing a maternity care provider. The first prerequisite to the achievement of equitable access and autonomy is that all pregnant people have the opportunity to exercise autonomous choice from an acceptable range of providers available within their local community. The second prerequisite is that all pregnant people are equipped with the enabling knowledge and resources required to support their ability to exercise informed and autonomous choice of provider. The third and final prerequisite is that all pregnant people are empowered to recognize themselves as agents with the normative authority to exercise autonomous choice of provider. Finally, maternity care systems that have established the policy and structures required to enable the fulfillment of these three prerequisite processes have the means of achieving two targeted outcomes. First, equitable realized access to the full range of maternity care providers. And second, equitable realized autonomy in choosing a maternity care provider. Within this framework, a system's success in achieving these goals and the lessons learned along the way can be fed back into the maternal health policy in order to enable the refinement of person-centered care, information, and resources. In sum, this study enabled the identification of underserviced areas where pregnant people's choice of a maternity care provider may be restricted by issues of service capacity and/or geographic access. It also highlighted the critical importance of rural maternity care programs, satellite practices, and home care to upholding access to care closer to home. Our findings also highlight the potential of alternative funding models and coordinated leadership to support pregnant people's access to the full range of maternity care providers by fostering innovative person-centered models of collaboration and promoting the sustainability of practice within the maternity care workforce. Finally, our findings suggest that developing coordinated and tailored education and informational resources could facilitate informed choice of an appropriate provider by providing pregnant people with the evidence-based information about provider options, the characteristics of these providers, their availability, and the process to access their care. A central information portal was considered to be particularly valuable as it would render this information directly accessible to pregnant people and would enable informed choice regardless of where pregnant people began their journey in the maternity care system, whether that be with their primary care provider, in a walk-in clinic, in an emergency room, or on the internet. We hope that our findings will provide local policymakers with an evidence base to support the development of systems of maternity care that are equipped to equitably support both patients and providers' experiences and outcomes. Now I'll turn it over to Darlene to support next steps.